The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Collis.
Okay, welcome back to the Knee Gurus. I'm your host, Bevan Collis, and I'm very excited today to have with us on the podcast one of Australia's top knee surgeons, Justin Roe. Justin has a special interest in osteoarthritis and ACL surgery, and he actually operated on my ACL back in 2007 after I injured in my first season in Niseko snowboarding. I've had a great outcome. I'm dealing with a bit of osteoarthritis in my other knee, but I don't think we can pin that on Justin. He's operated on many of Australia's top athletes, and he's also a keen skier himself. He's come into our clinic in Niseko to do a presentation for our team. Certainly one of the most renowned knee surgeons in Australia. So thanks very much for coming in, Justin.
Thanks, Bevan. Thanks for having me.
And so how long have you been specialising in knee surgeries? And do you know how many knee surgeries you might have performed in your career?
Yeah, well, I finished my general orthopaedic training in Sydney and in 2001, and then had the opportunity to travel overseas on a fellowship in 2002 to London, Ontario, Canada, in the Fowler Kennedy Sports Medicine Clinic there. And that was a great experience, learning from the Canadian orthopaedic surgeons, and Pete Fowler certainly is a guru in the area of sports medicine and is one of my mentors, as well as Bob Litchfield and Bob Giffen and Sandy Kirkley, who unfortunately passed away in that year in a tragic plane crash with her husband. So that was a very memorable experience in more ways than one for me. And my love for knee surgery and sports medicine sort of continued on then in 2003 when I travelled through Europe on a travelling fellowship working in Belgium and Milan in Italy, and visited Florence, and then came back to Sydney in 2003 working and assisting Merv Cross and Leo Pincheski, and did a fellowship with Leo Pincheski, and then set my banner up in the clinic in North Sydney Orthopaedic and Sports Medicine Centre in the beginning of 2004. So spent a fair bit of time getting subspecialised training, and then started in private practice, and I was doing some locum work in public, but didn't get in a public appointment. It was very competitive and busy at that time, and so stayed in the private setting and have continued on since then. I've done a few knees in my time, and when you consider probably, and I think it's important to note as an orthopaedic surgeon to do, which I've done, close to 5,000 ACL reconstructions. To get to that point, I've probably had to see over 15,000 patients because probably I would only reconstruct about 30 to 40% of patients that I see. So seen a lot of knee injuries, and close to 4,750 roughly ACL reconstructions. Knees go on and do unfortunately wear out and get arthritis, whether that be due to a genetic predisposition or sporting injuries or lifestyle factors. And I've done about 1,700 total knee replacements. And in that mid stage of, you were mentioning it, Bevan, maybe you've got osteoarthritis in your middle ages. We haven't yet solved that, and we can do some realignment surgery, or what we call osteotomy surgery. And I've probably done about 150 to 200 osteotomies to realign knees to try and offload the worn areas of arthritis to allow younger patients to stay mobile and active without having to go down the track of knee replacement surgery. So knees from the cradle to the grave, as we sometimes refer it to. That's my training and that's my interest. Yeah.
Oh, nice one. I love talking about ACLs because it's what we do in the ski clinics, and we talk about it all day, every day with people that have just ruptured their ACLs, and it's also controversial, and it's quite there's always some new discoveries coming to light. But what I find when I'm talking just with friends or someone at a dinner party who finds out that I'm interested in knees, most of the general population that I meet anyway don't tend to think much about ACLs unless it comes across their horizon. They go on this very steep learning curve where they try and learn everything about it while they're deciding how to manage it. But what people are always talking to me about is osteoarthritis. And, maybe they had a knee injury years ago, as you said, and then they're now dealing with knees that are painful and swelling regularly, maybe. And maybe someone's told them in the past they've got a knee of a 70-year-old or something like that. And that osteoarthritis kind of hangs over people 24/7. So what you mentioned, osteotomy surgery, what sort of other options are there for people that are suffering with osteoarthritis of the knee in particular?
Yeah, I think when talking about osteoarthritis, I think, as I mentioned, the underlying causes are important to identify, and really they can be grouped into three main categories. The genetic predisposition, so you can have someone who is of slight build in their 60s, never really run marathons or played netball or had skiing injuries, and they end up with arthritis, and that's primary osteoarthritis, and that often affects the knees and the small joints of the hands, so and more often in females. And then you've got the post-traumatic knee osteoarthritis, and then you've got the lifestyle factors, and obesity is probably the biggest factor, is proven to be a causative factor in osteoarthritis. So if we can look at those three factors and look at options of treatment, you can't change your genetics, you can't change the past, but you can change the present and the load going through your knees based on your body mass index or your weight. So generally, the first thing to encourage people to do to manage symptoms from osteoarthritis, the pain, the stiffness, and the loss of function from osteoarthritis, is to try and lose weight or get to a normal weight, and that can be achieved through a whole bunch of things. People often say, well, I can't lose weight because I can't exercise, exercising does not always mean you have to get up and go for a run. It does not always mean that you have to get up and walk. There are knee-friendly exercise programs which we should be initiating. There are diets and wise eating which we should be educating and instituting how to eat and what the right foods to eat. And even now, with some evidence, there are anti-inflammatory foods or anti-inflammatory diets that people can institute. So looking at the factor of obesity and getting weight in a normal range will certainly offload the knee. Now, osteoarthritis is an inflammatory condition, and that word is simple. Osteo is bone, arthro is joint, and itis is inflammation. So if we don't look at treating the inflammation, well, then we, again, putting our heads in the sand, we need to be able to treat the inflammatory flare-ups that occur, and anything we know and is proven to reduce inflammation can and should be helpful, whether that be, as I said, dietary, chemicals in the form of anti-inflammatory drugs, or intra-articular anti-inflammatories, are all known to modify the symptoms of the inflammation associated with arthritis. So I think, and exercise, the right types of exercise, as I said, to try and not only lose weight, but to maintain joint mobility and joint function. So there is a huge amount of evidence that the right types of exercise will help treat osteoarthritis symptoms. manage the pain, manage the stiffness, and manage the loss of function, which all our patients experience with osteoarthritis. So I think from that point of view, that's how I try and educate patients on the treatment, the modifiable factors that we know are causative in the symptoms. Now, then we get to the other things that are out there, the lotions and the potions, I say, the proven and the unproven, the myths and the truths. And there are a lot of potentially non-scientific remedies out there that do work. Anecdotally, but patients will always come to you with a story that someone told them to take this or rub this on or stick this patch on, and a patient will say that it's helped me with my symptoms. It's like also patients report symptoms in certain months of the year or certain weathers. We don't know why that occurs, but it is phenomena that we see. So the range of supplements, dietary supplements, glucosamine, chondroitin sulfate, fish oils, omega-Bs, all those things are out there with some evidence of some level of evidence, but certainly I can't look my patients in the eye and say this is going to fix things 100% of the time. So it's a trial. It's managing the symptoms, trying things, trying not to change too many things, trying not to add too many things, and trying to be honest and say that you don't always know whether this is going to work. Injection therapy, the various injectables are out there. And why are they developed? They've come about through the simple thing that anti-inflammatories work, intra-articular anti-inflammatories work on the symptoms of inflammation associated with osteoarthritis. So if you can get some relief from the injectables, and out of that injectables, injecting anti-inflammatories like corticosteroids, there's come a whole range of injectables, hyaluronic acid, PRP, and fat-derived stem cells, bone marrow-derived stem cells, all these various things, which probably in essence, even though there's a range of literature to support or not their use in various ways and various formulations, the main effect probably is an anti-inflammatory effect. I think the discussion on trying to regrow cartilage, trying to modify the environment of the knee, try and retrain or harden up the subchondral bone, desensitize the subchondral bone to reduce symptoms. All these things are out there, but in the environment of an arthritic knee, with the various factors, enzymes going around in the knee, which is a catabolic process, everything's breaking down. It is hard to say that we've got a holy grail where we can inject something in there or paint something on the surface or implant something on which is biologic, which is going to survive that toxic environment. So it is a cascade. It is a cascade which is towards destruction rather than rebuilding. Anabolic. It's not anabolic. It's nothing really rebuilds that articular cartilage and that subchondral bone. Unfortunately, it all is slowly getting destroyed or changing in its architecture, and the rate at which it changes probably affects people's symptoms and how rapidly they progress. Or you might see some people who have what I call a cold knee. Their X-ray looks horrific. Their X-ray looks horrific, but they come in and they say, "No, doc, it's not that knee I want you to see. Talk to me about the other knee." And on X-ray, their weight-bearing X-ray, their joint space is sort of narrowed. It's not bone on bone, and it's that knee that is painful, not the bone-on-bone arthritic knee, which I call the cold knee, which I think because the catabolic process is probably finished, it's there as it is. And some patients say, no, I can live with that. And from a physio point of view and a patient education point of view, getting to that state might be tough, but if you can get there and maintain some mobility and flexibility in that arthritic knee as it goes through that catabolic angry state, and you can maintain motion, flexibility, lots of patients live with their arthritis, and even though their X-ray looks bad, we don't operate on X-rays. We operate on patients. Patients can feel better, even though their knee looks a little bit knobbly, is a little bit stiff. But if it's got a good range of motion and achieves full extension, and they can flex it up, patients can tend to, and the deformity is not too great, they can tend to manage their arthritic knee like that as well, settling it down. So that's probably, in a nutshell, how I would, emphasize or discuss managing arthritis with my patients. Yeah.
So it's kind of reassuring for some patients who are dealing with a knee that's swelling up regularly to think that maybe you called it sort of a catabolic phase or maybe an inflammatory phase of, they might be able to go through that and come out the other side where the knee's not swollen and the body's, I guess, stopped going into an inflammatory response to the lack of cartilage, and the knee becomes calmer and perhaps that becomes less painful and maybe they can live with that. So you reassure patients.
I really
try
and encourage patients to work through that. I know it's so hard. As human beings, we really want it fixed here and now. We really want a result. We really want something done, in inverted commas. So if all people dealing with patients with osteoarthritis can, try and encourage that process to settle, I see so many patients who do settle and go on, and in follow-up, because I do try and institute a good follow-up of my patients after any form of treatment, and that's what hopefully I've become a little bit renowned for, is keeping data, following up patients well, and even with our non-operatively managed osteoarthritic patients, in follow-up we have a pretty good outcome in trying to in they saying, yep, things have settled. And it doesn't mean that with every year that goes by, people come to joint replacement. They do. And really, realistically, in all the studies around the country, the world on, health economic studies, of 100 people who have arthritis, 15 every year do end up getting some form of knee replacement surgery, so intervention. But it's not 85, right? So I try and give all these people I see encouragement that they've got a good chance of settling and getting through another year, managing their knee and living as comfortably and functioning as they can, and avoiding knee replacement surgery.
And what tends to be the last straw that causes people to bite the bullet? Is there one tell that you say, okay, if this is happening, it's probably time to go for a knee replacement? It's a natural decision, obviously, but
it is, and I think it's a shared decision, right? And I really don't like people coming in and meeting me for the first time on the whole, and me making a decision or helping them or supporting them in the decision, saying, I've got to have a knee replacement. First thing I say is it's not cancer, thankfully, and I work in an industry, a part of health, which is related to lifestyle rather than life-threatening conditions. And so, but then it is multifactorial. Bevan, you're right. It's, age. Age is a big factor, because age is something we can measure, and we measure it well around the world in our joint replacement registries. Age, we can't really measure surgeon expertise apart from number of surgeries done per surgeon per year. But age of the patient, BMI of the patient can be measured, and those patients who are older and those patients who have a lower BMI, closer to normal, do better with regards to longevity of the implant and patient-reported outcomes, so subjective measurements, patient satisfaction. So if I can encourage patients who are younger to manage it as best we can, But there are young patients who do come to surgery, and deformity, increasing deformity, loss of motion. So whether it be a big varus deformity, so bow-leggedness or knock knees, that with gait is really being exaggerated with what we call a thrust. And then that has an effect on the other hip and the lower lumbar spine and leg lengths and a whole range of factors. As soon as that deformity starts to snowball, that is probably a factor that I use. And I say to patients, certainly if they've got arthritis or we're managing, take a photo of yourself in the same spot every year. And if your deformity is really increasing, well, that's a time to come back and see me. The Harbour Bridge deformity, so an inability to straighten their knee. For me in Sydney, it's easy because we know the Harbour Bridge. If they are straight and they maintain that straightness on the bed is good, but if the knee starts to become like a Harbour Bridge and they can't push it out straight, that is also a factor that will affect their quality of life and their function rather than necessarily their pain. And then, of course, pain. Pain is a really individual experience, and it's so hard to measure each individual's pain. So we have to, as doctors, be receptive of people's individual pain. We have to listen to their pain and make sure that it's not an unusual type of pain. If it is, we have to investigate further. But if it's a fairly classic osteoarthritic pain that's constant, that's interrupting sleep, that's not responsive to oral analgesics and pain medications, that's one of the factors that obviously is helping in patients come to that decision to say it's time. And I say to patients, every patient who's been through a knee replacement who's in hospital today will have an individual experience if you go up and talk to them in their hospital bed. They will all have an individual experience about what made them make the decision to consent to coming into hospital and having the orthopaedic surgeon operate on their knee. It's a very individual experience, but it is a journey that they've been through individually themselves and with the family around them. And the decision-making process has come to the point where they make that decision. Out of all those people who make that decision are in hospital at one point in time and have had a knee replacement, 90% of them will be happy with that decision 12 months down the track, all right? So it is a big decision to make. We do face it a lot, and a lot of knee replacements are going in around the world because our population is aging and osteoarthritis we haven't got the cure for. But if the patient goes through a knee replacement, whether it be in the public system or the private system or in India or in Japan or in Europe or in Australia, our reported satisfaction is in the order now of 90%. I know there's been a lot of talk about the 80% number, 1 in 5 being dissatisfied and disappointed. Those studies have now been starting to be disproven, and our accuracy and our success rates and satisfaction rates are getting around 90%. And so it's an operation that we do and we don't go into lightly, shouldn't go into lightly, and hopefully with good modern day techniques, good modern day knee replacements, we give patients a good outcome 9 times out of 10.
Yeah, and it's always been that hip replacements had slightly higher satisfaction rates, but you're saying that the rates for satisfaction for knee replacements are going up to the level where they're similar to hip replacements, by the sounds of it.
I think hip replacements are probably increasing a little bit. I think hips are always going to be a little bit better than the knees in big long-term registry studies. I think the technology for hip replacement is so much better now too, with the ability to image the spine and the ability to recognize different spinopelvic anatomies and adjust implant position to suit those individual patients. I think our hip replacement satisfaction is going up as well, Bevan. I think too. Yeah.
It seems like there's rarely revisions done on hip replacements these days. It's kind of gone to the point once you've done a hip replacement, it's good for the rest of your life. But a knee replacement,
as long as it doesn't dislocate, and as long as you've got equal leg length, and as long as we can eradicate infection. I think any arthroplasty surgeon, hip surgeon, they're the three main things that will bug them. The three main things that will bug a knee replacement surgeon, yes, infection, stiffness, and dissatisfaction. So a patient, for some reason, which we can't put our finger on, just not liking the new knee that they've got under their skin. And it's a phenomenon that we see, we haven't solved, and we're trying to deal with different patient-specific ear alignment, patient-specific implantation. And so, I think it's still that we haven't solved everything. That's why we shouldn't be doing it willy-nilly. And patients should be informed about the main potential complications and dissatisfaction rates and why. And if we can eradicate infection in our orthopaedic community, we'd love it. But the bugs are smarter than us, I think, and still get through the cracks. Yeah.
And how long are most of your patients or in the industry getting out of a knee replacement now on average?
Yeah. Again, it's a good question and common asked by the general public. And you have to realise it's just like a new car that you buy from the salesman, and you say, how long is this going to last? He'll say, firstly, how hard are you going to drive it? You've got to look after it. So I think if we take that factor away and say that, any patient who has a knee replacement in is going to understand that it's an artificial knee. Artificial knees are made of metal and plastic, basically, and if you drive them hard, they can wear out. So, again, it's very age specific. We can't measure exactly what a 65-year-old male does who weighs 95 kilos versus a 65-year-old female who weighs 70 kilos, or a 90-year-old versus a 55-year-old. So our data on revision rates for wear or the implant wearing out does vary based on age, really, alone. The younger you are, a higher chance of the knee wearing out over time, such that, the Australian Joint Replacement Registry has got a 21-year history, probably one of the best histories in the world, with producing data that would say if you're a 65 to 74-year-old patient and you come into my hands and have a knee replacement, that in 20 years, you've got about a 94% chance that knee will still be functioning, all right? Mm-hmm. Whereas if you're under the age of 55, you've probably got a chance over the next 20 years that you'll close to 40% chance that your knee will have worn out in 20 years, all right? So any younger patient who is saying, you've got to give me a knee replacement, doc, you have to say, okay, well, not only one knee replacement, but are you going to be ready for the second knee replacement when you're 75 or 76 or 80 or 85? Because that's a percentage chance, high chance that you'll need that. So I think, it's they last well, and if they're put in well, they should function well, and they last for a long period of time. But the younger you are, the more chance, the higher chance you have of needing a revision down the track.
So for our listeners who are maybe in their 40s or 50s with arthritis in their knee and they're trying to put off knee replacement as long as possible, or perhaps even avoid it altogether, we talked about some of the other options, but surgically, in Japan, they're still doing the microfracture surgery that I believe was invented or founded by Richard Stedman, or there's the
Richard.
Cartilage transplant. What are your opinion on those surgeries?
Surgeries, yeah. I think we have to define which scenario we're treating. Isolated traumatic cartilage lesions, okay, in a middle-aged patient who, twists on the soccer field and takes a chunk of cartilage out. Oates microfracture, osteochondroplasty, are reasonable options. But I think they are a fairly big intervention for usually a fairly small problem, small percentage problem. The most common thing in that group that you describe is early post-traumatic osteoarthritis or early primary osteoarthritis that's coming on. So Oates and microfracture, and most of these cartilage transplantation type procedures that have been described over the years aren't suitable for early osteoarthritis. The early osteoarthritis is often a multifactorial thing where 40-year-old, 45-year-old male, he's got a failing meniscus. It's myxoid change in it. It's failing at its posterior root attachment and extruding. Patient might be a little bit overweight. They've got some generalized cartilage wear through the weight-bearing area on both sides of the joint, the femur and the tibia. So those sorts of patients who are, again, malaligned, potentially a little bit varus, a little bit bow-legged, I think realignment surgery or the osteotomy surgery has been around for a long time. It's stood the test of time, and it has good outcomes in those patients who want to remain physically active. So I assess patients' alignment really thoroughly, just to make sure that if there's any malalignment, that we talk about correcting that malalignment rather than going through the isolated cartilage replacement type surgery. Yeah.
That osteotomy, I was speaking to a surgeon the other day who's kind of the opinion that maybe it's underperformed. We could say that. It's a little bit of a hard sell. And
it is a hard
scary
sell
for a patient.
It is scary, and it takes patients time to get over. Yeah. And you ask a retiring surgeons, John Bartlett from Melbourne's great, one of the pioneers of knee surgery in Australia, and he's a really honest and humble man. And he said, Justin, if I had done more osteotomies in my younger years, more osteotomies in my career, I think I probably would have had more happy patients, right? So, but it is a hard sell. It is a hard sell. And I think the osteotomy is becoming easier to plan and easier to perform. And hopefully from that, patients will realize it's easier to recover from. And so that's, I think, an exciting prospect for the future is doing more osteotomies, getting younger patients straighter and better aligned, and giving them an improvement through their 40s and 50s into their 60s, or forever. Yeah. Without arthroplasty.
Yeah. All right. Hopefully that's given our listeners some ideas on how to manage the osteoarthritis. Just moving on from that, the number one injury we see in the ski resorts actually is MCL tears. It's a bit of a maybe a sort of, and people dismiss it a little bit. Oh, it's just a little MCL tear, and it's unlikely to need surgery. But maybe there's a school of thought creeping back that the MCL is actually a lot more important and is a primary protector of the ACL and of the knee as well. So maybe we can talk a little bit about MCL tears and how they should be managed. One of the things that we're always talking about with our patients in the early phase of an MCL injury is range of motion restriction and what is ideal. And it seems like one of our senior physios, Wenny Tan, did a master's on range of motion restriction for MCLs, and it doesn't seem like there's any universally accepted best angle. We tend to go between 30 or 40 and 90 degrees, but I know Australian surgeons tend to go locked at 30 for your high grade MCLs. Do you have any opinions on that?
Yeah, I think, Bevan, we're entering into that area of myths and myth busting. Unfortunately, musculoskeletal medicine has the highest number of unproven treatments in medicine, and this is one area. So I think where it's come from, I think where this idea of range of motion restriction has come from is when you do your MCL, and you'd know more than me because you see them coming off the mountain. And a trivia question: what's the most commonly ligament injured in the knee on the ski slopes? You know, I agree, it's the MCL, it's not the ACL, but the ACL is the most popular. That's ACL is most popular injured ligament on the ski slopes, but the MCL is the most commonly injured. MCL injuries are sore, and I tell my medical students, I teach my medical students what's the cause of a locked knee, and they all go bucket handle tear, but the MCL injury will often appears locked, like a locked knee. Why? Because it hurts so much. Patient goes into spasm and they just don't want to move the knee. So that's, I think, where the bracing and the 30, locking it at 30, it's like a plaster. You wrap someone up in a plaster or a splint if they're injured. And I think that's where the MCL, the bracing has started. Let's keep these knees quiet for a period of time. And when these range of motion braces came out, before that, surgeons, doctors used to just put a back slab on, a plaster back slab. And when they come in the emergency department, they were comfortable lying over a pillow in about 30 to 50 degrees. They just lie a big wet bit of plaster on them and then wrap them up and then send them home on crutches. And they bring them back, 2 weeks later, and they examine them. So I think the range of motion brace, that 30 degrees is where that started. Then you come to us colonials in Australia, as Dr. Pete Fowler used to call me. I was a colonial, and basically that blocked restriction off full extension came out because you put them into full extension, you put a limb into a longer position with a foot attached on the end. It's just like a ski attached on the end, and it twists. You twist that foot, it hurts that MCL. Whereas if you've got a flexed knee and your toe on the ground rather than your heel hitting the ground in full extension, you won't twist your foot as much, and so you won't hurt the MCL. So that 30 degrees of flexion allowed that ligament to be a little bit more relaxed and not be subject to that valgus load with the foot on the end of it. And 90 degrees was a little bit of motion, which we liked. We didn't want them to stiffen up too much. We liked a little bit of motion to 90 degrees. More than 90 degrees hurt because they often had an associated effusion, right? And if you forced the knee past 90 degrees, it would hurt. So the bracing was always designed to just allow the ligament to heal in a relaxed position rather than a position under tension. And we know that the MCL's it's extra articular. It's outside the joint. It's not bathed in joint fluid and enzymes and catabolic breakdown products. It's in the soft tissue. It's got a good blood supply. It's got a great nerve supply. That's why it hurts so much compared to the ACL, for example. And it's extra articular. So it has got a very good potential for healing. It's broad. The LCL has a potential for healing, but the LCL is tiny, little wisp-like structure, and is more associated with all the posterolateral corner structures and the mid-third capsule. The MCL is a wide, broad structure. It's got a deep and superficial component. It's got a fan-shaped attachment distally, and it tends to heal when it's not stressed, and it tends to heal well and reproducibly. But with with time and evidence and research, we have seen that we've missed a lot of MCLs, or a lot of MCLs haven't really healed as well as we'd like. And it's usually often those MCLs in association with an ACL, because the ACL is actually the medial ligament, is the lateral ligament of the medial compartment. So if you've got an ACL ruptured and an MCL ruptured or torn or sprained, well, if the ACL is not fixed, the MCL tends to heal in a lengthened position. So then you go and fix the ACL and the MCL is still a little bit wobbly. That puts more pressure on the ACL. So then we get failures, ACL failures, when there's MCLs that are being missed. So there has been a renewed interest in being fairly aggressive, a little bit more aggressive, with patients with ACL and MCL combined injuries. They're going back to the isolated MCL, the femoral side with capsule and synovial layer intact, right? So not a complete pull off where you've got hemarthrosis and synovial fluid up through that medial quad, but just we're saying a grade 2 that's capsules intact. They heal well, but distally, we're a little bit more aggressive now because we have learned of the Stenner type lesion where the superficial MCL does flip out and sit above the pes. And I actually had a young gymnast from the Olympic trials in the Gold Coast come down on Monday, and she had a classic Stenner lesion, which was the superficial MCL pulled up. So those ones don't tend to heal, and we are being fairly aggressive with those ones. And again, it's always dependent on the patient's environment, their expectations. So say a rugby league player, they get the MCLs a lot and they get a distal MCL. And if it involves the deep and superficial, surgery on that allows a good solid fixation, then an accelerated rehabilitation. So a player can be back playing 6 to 8 weeks after surgery, as opposed to being in a brace for 6 weeks and then getting stiff and then rehabilitating for another 3 months. So it is patient specific. Distally, we're a little bit more aggressive on, and in combination with an ACL injury, we're probably a little bit more aggressive on. The big discussion in our world, the orthopaedic world, as opposed to the general community physios, is how you actually reconstruct it. That's a lot of discussion. Right? So you got to pick that your surgeon hasn't just read a journal saying, "Oh yeah, we should be fixing them." A surgeon who knows how to fix them and has done some work with surgeons who are fixing them or has been taught how to fix them, I think is pretty important too.
Yep. And just going back to that point of range of motion restriction to facilitate healing, which is obviously a very hot topic in soft tissue management tears of all types. How important do you think the actual approximation of the torn parts, or the you were sort of alluding to, maybe it's just the position of most comfort? Do you think there is some physical positioning of the torn ligaments to get them as close as possible?
I don't think so.
To facilitate healing?
Yeah, I don't think so. And I'm really sort of concerned about a lot of the publicity of the bracing protocol and in ACLs and how that fracture sort of analogy has been proposed to correlate to an intra-articular ligament injury. But that's another story which we can talk about later if you want. But how important is it? No, I don't think it's hugely important, because the MCL injury is not just a tear in one plane. It's often a rotational thing. So superficially, you might have some proximal fibers torn. More distally, you might have some deeper fibers. And more distally, then you have some posterior fibers, for example. So it's a three-dimensional injury. So I don't think just saying 30 to 90 is going to magically fix everything. The Americans, for example, I was getting to the colonial comment, the Americans think 30 to 90 is archaic, is silly. And I too tend to agree. I think it's very patient-specific. First of all, it's comfort, and then it's alignment. Varus versus valgus. So a lot of varus knees, you don't have bow-legged legs, you don't have to put them in a brace. But someone who's valgusly aligned, which a lot of our Samoan footballers or our Pacific Island footballers who are in valgus, yeah, I either fix them, I put them in a brace, or I fix them, because their alignment is valgus, and that's the biggest factor to prevent healing of the ligament. So apposition and loss and taking away the stresses is important. So I don't think range of motion has really been proven that well. So you'll have some people who brace themselves. And I think for physios, all your physios probably know most, that patients come in and some are really stiff and they don't need a brace. And they're going to heal like wildfire. And some come in 2 days after the reported injury, with an MRI scan showing a huge amount of soft tissue edema and bony bruising on the lateral side. And they're walking as though nothing's happened. So I think it's really important to not just have protocols all the time, but really have a knowledge of treatment and underlying pathophysiology, but apply it to each individual patient. I think it's really more important in my mind, assessing the patient. Are they a stiffy sore one? Do they need a little bit of bracing, or can you start moving them and pushing them straight away? MRI scan's important, and we continue to talk about MRI technology and MRI helping us direct our treatment. Yes, it's an investigation which helps us direct our treatment. So this day and age where MRI scans are on every street corner, a patient with an MCL really probably should have an MRI scan, unless you're absolutely certain that the ACL is not involved, the menisci are not involved, and it's just a simple grade 1 MCL. That's fine. But anything more, I think MRI scans are helpful to document the extent of the ligament injury and extra other injuries, bony bruising, cartilage, meniscus, intra-articular injuries. Yeah.
And what about kind of going back to the range of motion and approximation theory, I guess?
Yeah.
Talk about the cross-bracing protocol, I guess, that's got a lot of press recently. But in other soft tissue injuries, say as a ruptured Achilles or a mallet finger, where it's still kind of standard practice and belief to approximate the soft tissues to bring them as close together so they can heal. You're saying even no matter what the soft tissue, you don't think range of motion restriction will improve healing through approximation?
It's joint specific. So, if you talk about a mallet finger, extensor tendon, you've got to hold that in extension or hyperextension until it heals. Whereas a flexor tendon or a volar plate, it needs surgery. Achilles tendons, we've been through that non-operative. The Achilles tendon again is something that's been looked at with regards to even if the ends aren't approximated. If you there's evidence if you get that ankle moving and have controlled forces applied to it, functionally a patient can get back doing things they want to do. So the tendon injuries, I think, are a little bit different because you've got a muscle attached at one end. But the ligament injuries, I think, depending on which joint, and I'm obviously talking about the knee, the ligament injuries in the knee, either extra-articular or intra-articular. So extra-articular have a greater capacity for healing than the intra-articular. I think extra-articular ligament injuries need to be protected from stresses. And I think traditionally the extremes of motion are thought to be, in the early days, stresses, and the extremes of alignment, so varus or valgus, anterior translation or posterior translation, or the other four corners, anterolateral, anteromedial, posterolateral, posteromedial. If we go too far outside the envelope, you'll obviously get a potential for failure of healing or healing in a lengthened position. So I think early days, protecting that those ligaments to keep them within their construct of action, right? And that's what I think bracing is about.
Yeah. Okay. So maybe we can segue there to start talking about ACLs. I guess you've always been known as a hamstring guy, having been a protege of Leo Pincheski. You still sort of believe that a hamstring, or are you still doing hamstring semitendinosus gracilis constructions with most of your patients, or are you changing the way you're practicing a little bit then?
No, I think it is an a la carte option, more so than what it used to be. I think the old-fashioned argument was patella tendon or hamstring, and but for the last 20 years, even before that, my training, I think there was a trend away from that simple, I can call it archaic argument now, of it's either patella tendon or hamstring. Patella tendon causes arthritis, hamstring doesn't, hamstring tendon ACL reconstruction doesn't. If we could bust that myth, put that myth to bed, I'd be really happy. Unfortunately, sometimes it still keeps coming up. But or the other argument, patella tendon is stronger, ACLs stretch out. You know, those sorts of arguments do frustrate me a little bit, because I've got plenty of patella tendon reconstructions that aren't stiffer than my hamstring reconstructions. I've got hamstring reconstructions that have got had cyclops lesions, and patella tendon reconstructions that haven't. I've got patella tendon reconstructions that have gone on and got some arthritis, and hamstring tendon reconstructions that have as well. And I've got plenty of others who haven't. So moved on from that, just due to popular demand, the hamstring tendon reconstruction is still around the world the most commonly done. Why is that so? Bottom line is, it is easier to do. And it is easier to do, okay? And when it's easy and it gives a good outcome in most people, why not do it? Okay. The patella tendon reconstruction, for me, is also easy to do because I've trained in it. I've trained by one of the best patella tendon reconstruction surgeons in this country, Merv Cross, who's now passed, and he did them in his sleep. And he was in that wave of the 80s and the 90s of pioneering the ACL reconstructive surgery, and dare I say it, doing it on everyone. Okay. So I worked for him and with him and saw him, and I still use the majority of the technique of the patella tendon ACL reconstruction that he taught me. So, and it's been shown in good studies to be suitable for patients who are hamstring dominant, for sports people, who are hamstring dominant. So often now I'll do it in a soccer player. And Andy Williams and his group in the UK, he's got 85% of his population of professional sports people, and he's shown that he probably has a lower failure rate using a patella tendon graft than a hamstring graft in soccer players. So the quads tendon, it's a graft that was old and now is new again. And dare I say, I think the quads tendon graft is a very tricky graft. We talk about the patella tendon being maybe a more difficult operation with potential more complications. The quads tendon is pretty difficult too. But what's happened with the quads tendon, it's come on board on the background of some guys having difficulty with the hamstring tendon graft or the patella tendon graft. So the quads tendon has made a new little bit of face because of technology. The tech companies producing instruments that potentially help harvest a quads graft. Allograft is certainly becoming more popular, because of the morbidity associated with the autografts, the hamstring, the patellar tendon, and the quads, they hurt or potentially hurt and create some morbidity. So the allograft takes away that morbidity. And if the sterilisation techniques are good and the graft, the quality of the tissue is good, and I think it will only get better with our organ and tissue donation programs all around the world. So allografts are out there, and I do use allografts in lower demand patients or patients who have had multiple reconstructions and we've run out of autografts. And then there's the discussion, research, new thinking. Can we take grafts from animals, in particular in this country, our bouncing kangaroos that a bit of a vermin, and we're doing some research on that at the moment. That's in a box that's developing in the background and a few years away at least from human clinical trials.
Yeah. Good one. So it's really not a matter of choosing the same graft for everybody. Work out the specific demands of each patient and choose the right graft for that particular person, giving all the variables.
Yeah, that's what I do. You've got to talk to your patients and find out who they are and what they. Sometimes it's just a simple case of, dad and daughter come in. Dad had his 25 years ago using a specific graft and he's feeling great. And it's lasted 25 years. Daughter comes in at the age of 15 or 17, and I say, well, let's do the same thing, right? And I think as a knee surgeon, any knee surgeon who's doing ACL surgery should be able to talk that way to their patients, in 2024, and say that, you sure, I might have a favourite, but I can, do an a la carte operation based on the individual factors and the shared decision-making discussion that we have with each individual patient. Yeah.
And regarding pediatric ACLs, I know a lot of the surgeons in Singapore are quite reluctant to operate pediatrically on pediatric patients with the extra risk of the growth plate. And where do you sort of stand on that? Do you have a minimum age that you try and delay ACL surgery until?
Yeah, I can say, Bevan, that I am, and this has been an interest of mine for many years, and I am recognised around the world as one of the surgeons who knows a lot about pediatric ACL reconstructions, and I've done a lot of work on it. And I think the growth plates have been a big taboo. We've learned a lot about growth plates and ACL surgery, and I say to parents that the risks of not operating on your child, or the risks of not giving your child a stable knee, whether it be through non-operative treatment or operative treatment, the aim of the treatment is for your child to have a stable knee. If that means they need a graft put across their knee to stabilize the tibia and the femur in a rotationally stable construct, my concern is not the growth plate. My concern is getting it in the right spot and getting that child a stable knee, because if they don't have a stable knee, there's much more evidence that damage to the cartilages and the menisci, the intra-articular structures, intra-articular damage will cause a lot more problems than a growth plate injury that creates maybe an angular deformity that, again, can be picked up and corrected very well with modern-day growth modulation treatment, or a shortening or a lengthening, which can again be treated very well with modern-day growth modulation techniques. So the intra-articular damage that is irreversible is far more a risk than a growth plate injury, angular length. So I go ahead and I use a safe technique, which is a transphyseal. So we drill through the growth plates, and then we use a soft tissue graft, and that's why my tendency for hamstring graft is I probably do use more hamstring grafts because the average age of my patient population is in the order of 21 or 22. So I am skewed to the younger patients. So I use a soft tissue graft, and I keep the size of the graft fairly low. So the cross-sectional area that I drill through the growth plate is low. And then I fix it above and below the growth plate, and I monitor that child every year till their 18th birthday. And we've got, good long-term studies to show minimal risks to growth plates. And there are, unfortunately, some studies where patients have unstable knees and they result in osteoarthritis or intra-articular damage with unstable knees. So my aim is to give them a stable knee and to monitor their growth and adjust their growth if needs be. But that's very rare that we have to do after a well-performed ACL reconstruction.
You usually find they don't have trouble with developing leg length discrepancies as they grow up?
The incidence is less than 2% in our series, Bevan. It doesn't mean we haven't got them, but, in 450 patients in a group, we've got about 380 of that Tanner 1, 2, and 3. So how we grade their growth is the Tanner staging. And it's not necessarily age. So you mentioned aged. Age is not always. You can have a 12-year-old girl who is fully mature skeletally, and you can have a 12-year-old boy who hasn't started puberty, he's prepubescent. So it's all about their stages of puberty, their adult growth characteristics. Yeah.
So you generally would you take that level of development or whether they've gone through puberty into account?
So do you wait? Yeah. Do you wait? And I think where I prefer not to operate when they're really in the middle of that growth spurt. Okay. So for females, it's usually about 18 months before the onset of menses. And then it tapers down for that 12 months after. And for the boys, it's harder. You've got to really go by growth charts or growth history of growth. If they're going 1 centimetre per month, and some boys are, or more than a centimetre per month. So you can have a boy that you see now, and then in 6 months' time, he's 8 centimetres taller. That's probably not the best time to operate on them. So if I can, I really get an idea of where their growth spurt is. And if they're in the middle of it, I'll brace them or educate them. It's hard to educate boys, probably easy to educate girls. Just take it easy for that period of time. And we come back and we watch them grow, watch their growth velocity slow down, and then we get on and stabilise their knee. And let me say, Evan, this is for knees that are unstable, proven to be unstable, both on examination and subjectively. They've gone out numerous times before they see me, or in the process of doing some physio, doing some prehab, doing some rehab, just recovering from the injury. Their knee keeps going out, or they've got intra-articular pathology in association with their ACL, meniscus or condyle damage that needs to be treated. Okay, they're the kids that really need to be reconstructed. And from my point of view, with respect to the numbers, how many of those that I see, I don't know how many are out there in the world, being wrapped up in plaster, being missed, the diagnosis being missed. And I think that's probably the most common, how kids get away without having ACL reconstructions, is the ACL injury itself is not picked up in the first place. But if it is, I don't know if they're out there, but I would about 90% that I see are unstable and need to have surgery, all right? Those under the age of 18. It's a hard group to manage, and we get criticised for the re-injury rate, if I operate on 90% of those that I see under the age of 18 because they're unstable. I'm automatically picking a group that are hard to treat. And so they're going to go back to sport And I've heard a lot of people talk about return to sport rates being only 50% after ACL reconstruction. I've got evidence, and there's evidence all around the world, that the group under the age of 21 who their return to sport rate is in the order of 85 to 90%.
Very high, yeah.
They go back.
Yeah.
And even if you haven't operated on them, you can't hold them back. They'll go back. So if their knee's unstable, right, they'll do damage. If their knee's stable, you have to accept that when they go back, they've still got a percentage chance of re-injuring that knee or the other knee, because they're playing the same sport that injured themselves in the first place. Yep. People say to me, why do you look after them? I say, well, that's what I do. But, I get a lot of satisfaction out of it. And a lot of kids will thank me. And I've got NRL players, just picked for the state of origin team in their twilight years. And I've done both his ACLs, right? You wonder how, and his first one was when he was 17. So, these guys that can thank me for their careers and thank a lot of us orthopaedic surgeons for their careers, something that gives us the rewards rather than getting criticised that they either re-injure the other one or get arthritis. It's a risk that they choose when they step onto the field.
Yeah. And lastly, we might have to get onto ACL healing and that whole hot topic another time. We have to get you back on, because we've been going over an hour yet, and there's probably it's probably another hour's conversation itself. But one of the things I did want to ask you about, and it kind of leads in nicely into the pediatric ACL, is about the tunnel angles that you drill and how important really getting those angles dialed in perfectly is to the actual efficacy of the graft.
Yeah, sure. I think from an orthopaedic surgeon point of view, if I'm talking to orthopaedic surgeons out there listening, tunnel position is paramount. All right, tunnel position is paramount, or graft position is paramount. So that's the technical aspects, and you hope that any of your surgeons looking after your patients, or all your surgeons, are being trained appropriately. In the pediatric patient, not only do we have to get our graft position perfect, but then to get there, we're thinking about the angles through which we're drilling the tunnels. If we're going through the physes, through the growth plates, if we're going within the epiphysis, right, you've got to stay away from the physis. So your tunnel trajectory is important as well. But I think, as I mentioned before, all in the pediatric patient, drilling through the growth plates, it's the surface area that we've got to keep to a minimum. So if you look at the math, the way you do that when you've got a round hole drilling across a plate, if you go at an angle, you're increasing the surface area, you're making it more oval. So we ideally aim, to keep it simple, we aim to cross the growth plates as close to 90 degrees perpendicular as possible. All right. So if you've got a 7 millimeter diameter drill bit and you cross that growth plate perpendicularly, that's going to be 7 millimeters in surface area squared, right? Whereas if you go at a bit of an angle, the more the angle, the more oblique, the bigger the surface area. So that's sort of the mechanics behind tunnel drilling in the pediatric patient through their growth plates. Technical, but nothing. That's what we think about. Yeah.
Yeah. All right. That's terrific, Justin. Thank you very much for your time. You've been very generous with your time, which is
pleasure,
valuable, and I hope our listeners have got some really valuable insights into how to manage those injuries. And yeah, like I say, we'll have to get you back on. I believe the cross bracing protocols just received funding for a randomized control trial that they'll be beginning later this year. Obviously, it's going to take a long time for the results for that to become clear, but Yeah, we'll have to leave that discussion.
And I think it's important that science helps prove theories. This is still a theory, and just as it's something that we do have to talk about, and just be careful that a lot of the airplay it's getting is based around still not robust evidence. And that's, again, to finish off, my one thing in musculoskeletal medicine is that unfortunately, there's a lot of myths. There's a lot of untruths out there which have been based on hearsay or popularity. And we just got to be careful in being extreme all the time. So running all the way this way to this news story about a brace fixing all ACLs, running away from the old story of Merv Cross operating on everything. So we've got to try, and hopefully the new age is we're here in the middle, treating each individual patient for who they are and knowing the science behind the different options.
True. All right, Justin. Thanks very much, mate.
All right, Bevan. Thanks.
No worries. See you later, mate. Thank you.
Yeah. See ya.
Bye-bye.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myokokogen.